ကျွန်တော်နာမည်ဟန်ကိုကကျွန်တော်ကမြောက်လာရွှေပေါက်ကမှနေရဲကျွန်တော်အခုကျမကြီးဝင်နေကျမကြီးလှုပ်သားနေတယ်လုပ်နေရပါဘူးကိုအန်ရရှိမှန်းသိတော့အခါမှာကုသမှုပေးရအဖွဲ့အစည်းမှာစစ်ဖြစ်တယ်စစ်ကြည့်တဲ့အခါမှာကျွန်တော်ဒီရှိတယ်ဆိုတဲ့အဖြစ်ရတော့ဆရာမတွေကိုထပ်ပြီးတဲ့အခါမှာပို့ပြီးတော့သိလာရတယ်ပေါ့နော်စီဘိုးကိုမခုပဲထားရင်အသေး6ပြီးတော့အသေးကင်ဆာမြန်မြန်ဖြစ်နိုင်ဆိုတဲ့အကြောင်းတွေသိခဲ့ရတဲ့အတွက်စိုးရိမ်တော့ပါတယ်ကျွန်တော်စိတ်ကူးဖို့အတွက်ကြတော့ကျွန်တော်ဒီစီဘိုးပြင်စိတ်ကမှစိတ်ခဲတဲ့အဖြစ်နဲ့မရဘဲနဲ့နောက်ထပ်ချင်းတင်အောင်လို့ပိုးကောင်ရေးစစ်တဲ့အဆင့်ကိုထပ်လုပ်ရပါတယ်အဲဒီပိုးကောင်ရေးဖြစ်ရတော့မှကျွန်တော်ကုသတဲ့အဆင့်ကိုဆက်သွားပြီးပါကျွန်တော်ကုတဲ့အခါမှာဆေးကို3လတောက်အောင်လို့ပြောပါတယ်ကျတော့ဒီစီဘိုးဆေးဟာအခြားဆေးတွေလိုမျိုးအလွယ်တကူတောက်လို့မရပါဘူးစနစ်တကျနဲ့အချိန်မှန်တောက်ပေးရပါတယ်ဥပမာည9:00နာရီဆိုရင်နောက်နေ့လည်းည9:00နာရီအချိန်မှန်3လတောက်ရပါတယ်မပြတ်မကွက်နေပါဘူးเนาะအဲ့လို3လတောက်ပြီးတဲ့အခါမှာနောက်ထပ်3လဆောင်ပြီးတော့ခုမှစီဘိုးယောဂပြောင်းမပြောက်ဘူးသိပြန်ဆေးကြည့်ရပါတယ်အဲ့လိုစစ်ကြည့်တော့မှကျွန်တော်စစ်ကြည့်တဲ့အခါမှာမရှိဘူးဆိုတဲ့အဖြေကိုသိခဲ့ရပါတယ်တက်ပြီးခဲ့ပါတယ်အဲ့ဒီအချိန်မှာဝမ်းသာတော့ဘာဖြစ်လို့လဲဆိုတော့မကုသပဲထားမှဆိုရင်နောက်ဆက်တွဲဆိုးကျိုးတွေများတယ်အသေးယောဂနဲ့ပတ်သက်ပြီးလှည့်လင်းမြန်မြန်ဖြစ်နိုင်တယ်တယောက်နဲ့တယောက်လှည့်လင်းမြန်ဒီအသေးစီပိုးဆိုတာလည်းကုသနိုင်တယ်ဆိုတာသိကြတဲ့အတွက်သူများကိုလည်းမကုသနိုင်ဘူးဖြစ်တဲ့အတွက်ဝမ်းသာပါတယ်တဲ့အောင်တော့စီဘိုးဟာကျွန်တော်ဆော့စစ်ပြီးတော့ဆော့ကုသမယ်ဆိုရင်ပျောက်ကင်းနိုင်တယ်ဆိုတော့ပျောက်ကင်းတဲ့ယောဂဆိုတာကိုကျင့်သုံးသိစေချင်ပါတယ်။ဟုတ်ဒီအတဲ့အောင်တော့စီဘိုးဆိုတာအရင်တော့လို့ကုသမှုမခက်ခဲတော့ပါဘူး။အခမဲ့ကုသနိုင်တဲ့ဆေးရုံဆေးခန်းတွေရှိရတဲ့ကျွန်တော်တို့တွေက live ပြောပြပြီးတော့ live ကပို့ဆောင်ပေးနိုင်ပါတယ်။ကုသမယ်ဆိုရင်ပျောက်ကင်းနိုင်တယ်ဆိုတော့ပျောက်ကင်းတဲ့ယောဂဆိုတာကိုကျင့်သုံးသိစေချင်ပါတယ်။ဟုတ်ဒီအတဲ့အောင်တော့စီဘိုးဆိုတာအရင်တော့လို့ကုသမှုမခက်ခဲတော့ဘူး။အခမဲ့ကုသနိုင်တဲ့ဆေးရုံဆေးခန်းတွေရှိရတဲ့ကျွန်တော်တို့တွေကပြောပြပြီးတော့ live ပို့ဆောင်ပေးနိုင်ပါတယ်။
देखाउने हो जुन बेला चाहिँ क्योर गर्न गाह्रो हुन्छ त्यसकारण सकभर छिटै ट्रिटमेन्ट गरेको राम्रो थाहा हुने बित्तिकै गरेको राम्रो तर आत्ती चाहिँ हाल्नु पर्दैन डाक्टरको सल्लाह अनुसार राम्रोसँग धैर्य गरेर काम गर्दा हुन्छ नमस्ते म कृष्णराज नेपाल शारीरिक लक्षण म सोसल म इन्जेक्टिभ ड्रग एक ग्राउन्ड हो जुन बेला चाहिँ क्योर गर्न गाह्रो गर्दाखेरि कारण सकभर छिटै ट्रिटमेन्ट गरेको नेपालबाटै आत्ती चाहिँ हाल्नु पर्दैन डाक्टरको सल्लाह 3 महिना आउँछ मेरो भाइरल लोड कृष्णराज नेपाल सुरुमा त मलाई एकदम गाह्रो भयो हेपाटाइटिस म इन्जेक्टिभ ड्रग ट्युबरकुलोसिसको बारेमा थाहा थियो एकदम डर पनि लाग्यो तर यसको क्योर छ अप्सन छ मैले क्लियर गर्नुपर्ने भएको सायद फर्स्ट क्लियर मैले स्वयं क्लियर गर्नुपर्ने भएको 3 महिना मलाई त्यतिखेर अरूले के भन्छ त्यतातिर नभइकन नातिकन आफ्नो ट्रिटमेन्टमा जानुस् शारीरिक लक्षण हतपत देखाउँदैन हेपाटाइटिस सी को शारीरिक लक्षण भनेको अलि पछि नै देखाउने हो जुन बेला चाहिँ क्योर गर्न गाह्रो हुन्छ त्यसकारण सकभर छिटै ट्रिटमेन्ट गरेको राम्रो, थाहा हुने बित्तिकै गरेको राम्रो, तर आत्ती चाहिँ हाल्नु पर्दैन। डाक्टरको सल्लाह अनुसार राम्रोसँग धैर्य गरेर काम गर्दा हुन्छ यसमा। नमस्ते, म कृष्णराज बजाचार्य, म स्पर्श नेपाल नामको एउटा एनजिओमा काम गर्छु। त्यहाँ चाहिँ म सोसल मोबिलाइजरको रूपमा काम गर्छु। म इन्जेक्टिङ ड्रग युजर थिएँ र यही क्रममा हेपाटाइटिस सी चेक गर्दाखेरि देखिएको हो। अनि त्यसपछि मैले चाहिँ स्पर्श नेपालबाटै औषधि खाएँ 2023को डिसेम्बरमा। अनि 3 महिना औषधि खाएँ, त्यसपछि मेरो भाइरल लोड हो फेरि अहिले अनडिटेक्टेबल छ। सुरुमा त मलाई एकदम गाह्रो भयो। हेपाटाइटिस सीको बारेमा त्यति राम्रोसँग थाहा पनि थिएन। अब एचआइभीको बारेमा थाहा थियो, ट्युबरक्लोसिसको बारेमा थाहा थियो, एकदम डर पनि लाग्यो। तर यसको क्योर छ, औषधि छ र स्पर्श नेपालबाट चाहिँ निःशुल्क खाएँ। अहिले ठिक छ। मैले तिरेर गर्नुपर्ने भएदेखि त सायद पैसा तिरेर मैले स्वयं तिरेर गर्नुपर्ने भए अहिलेसम्म पनि गर्न सक्दैन थियो होला मैले, किनभने त्यत्रो पैसा मसँग थिएन। यो WHO कै मार्फतबाट गएको औषधि थियो के अरे स्पर्श नेपालमा। स्पर्श नेपालले यही औषधिबाट मैले चाहिँ ट्रिटमेन्ट गरेँ अब निःशुल्क। सुरुवात लिनेहरूले हेपाटाइटिस सी एचआइभीको चाहिँ टेस्ट गराउनै पर्छ। आफू स्वयं गएर परीक्षण स्थानमा गएर चेक गराएको राम्रो, किनभने आफ्नो स्ट्याटस आफूलाई थाहा हुन्छ। थाहा भएपछि उपचार गर्न सजिलो हुन्छ। यो जुन अब लान्छना र भेदभाव भन्ने कुरा नि यो संसारमा यसमै रहने चिज हो। अब देखावटी नगरिदेला, उसको अघिल्तिर नगरिदेला, तर पछिल्लोतिरबाट भए पनि फलानलाई हेपाटाइटिस सी भएको छ भनेर त्यो अवश्य भनिदिएला। त्यतातिर जस्तै म हेपाटाइटिस सी भएपछि मलाई त्यतिखेर अरूले के भन्छ त्यतातिर नभइकन नआत्तिकन आफ्नो ट्रिटमेन्टमा जानुहोस्।
Thank you very much. We have finished the videos both from the country office of Myanmar and Nepal. Perhaps we shall start the webinar series webinar today. And maybe some housekeeping first. So thank you very much for attending today's WHO Southeast Asia Regional Office World Hepatitis Commemoration webinar, which is in collaboration with ECHO. Next slide. We will be talking about liver cancer as part of hepatitis. Let's break it down. So if you have questions, please use the Q&A feature for questions regarding the topic and presentations, or chat feature for questions regarding the IT or logistics, and to introduce yourself. So please tell us where you are from in the chat. Thank you. Next. There is live transcript for people who require the subtitles, and you can click on live transcript and choose show subtitle. And to close the caption, click on hide subtitle. Next. This session is being recorded and your attendance is consent to be recorded. The session materials will be uploaded into the iEcho platform following the webinar. And your feedback is also important for us. The survey will be shared at the end of the session. Next. Project ECHO collects registration, participation, questions and answers, but your individual data will be kept confidential. These help us in WHO and ECHO to refine and to improve the quality of the webinars and to share knowledge. Thank you. So without further ado, thank you very much. I am Dr. Pauline Chan. I'm the Regional Advisor for HIV, Hepatitis, STIs, and triple elimination of mother-to-child transmission in the WHO Southeast Asia Regional Office. So without further ado, I would like to invite my colleague and Director of the Communicable Disease Department of WHO CRO, Dr. Suman Rijal, for his opening remarks. Over to you, Dr. Suman.
Thank you, Pauline. A very good afternoon, good evening to you all. As mentioned by Pauline, we are here today in this webinar to commemorate the World Hepatitis Day 2025. And I would like to take this opportunity, and it's my privilege, to read out the message from Dr. Catherine Bohem, who is the officer in charge at Sierra. Quote, World Hepatitis Day, marked annually on 20th July, raises awareness of viral hepatitis and inflammation of the liver that causes severe liver disease and liver cancer. It is celebrated on the birthday of Nobel Prize-winning scientist Dr. Baruch Blumberg, who discovered hepatitis B virus and developed a diagnostic test and vaccine for this virus. This year, the theme, Hepatitis, Let's Break It Down, calls for urgent action to dismantle the financial, social, and systemic barriers, including stigma, that stand in the way of hepatitis elimination and liver cancer prevention. In our WHO Southeast Asia region, viral hepatitis continues to cause needless suffering, silently leading to liver disease, cancer, and hundreds of thousands of preventable deaths each year. Across the region, an estimated 61 million people live with hepatitis B and 9 million with hepatitis C. Our region bears one of the highest burdens of chronic viral hepatitis globally, yet most people living with the disease remain undiagnosed and untreated. Every year, over 260,000 lives are lost, many due to preventable complications of hepatitis. One of the most devastating outcomes is liver cancer because of untreated hepatitis B and C infections. With limited access to early diagnosis and treatment, most liver cancer cases in our region are detected late, when curative options are no longer viable. Hepatitis testing and treatment services must be scaled up, decentralized to primary care, and guidelines simplified to reduce the toll of liver cancer due to hepatitis B and C. We have the tools to prevent these infections, safe and effective hepatitis B vaccines, affordable diagnostics, and highly effective hepatitis B medicines, and the game-changing hepatitis C directly acting antiviral medicines that cure the infection. However, the problems persist with the complexity and fragmentation in service delivery, lack of services at primary healthcare clinics, poor uptake of its services, out-of-pocket expenses, limited awareness, and stigma. We must embed hepatitis services within essential health packages, leverage primary healthcare platforms, and align responses with maternal and child health, HIV, STI, TB, non-communicable diseases, blood safety, infection prevention and control, occupational health, and universal healthcare coverage efforts. We have to prioritize hepatitis B birth dose and completion of the vaccination schedule, integrated safe motherhood services, harm reduction services, and community-based outreach to close the equity gap. Progress is possible. Countries across our region are innovating, including adopting simplified testing and treatment service models, integrating hepatitis as part of essential services and under social health insurance coverage, and reaching key populations with dignity and compassion. These efforts need to be scaled and sustained with strong political will and investment. Together, let's break it down by removing the complexity, ending the silence, and delivering on our promise to eliminate hepatitis by 2030, unquote. So thank you very much for all of you for attending this webinar, and we look forward to the discussions and deliberations. And over to you, Pauline.
Thank you, Dr. Rijal. And to this World Hepatitis Day, and in particular, this webinar has something special. And it's special because for the first time in for WHO, we had a distinguished poet from Bangladesh that on its own initiative developed a poem for the World Hepatitis Day. So with absolute pleasure, I would like to introduce to you Mr. Ehsan Samad, who is a known Bangladeshi poet to talk about his poem. It's called The Liver's Lament. Mr. Ehsan Samad, over to you.
Good
Please
afternoon, all.
unmute.
Can I switch on my video, please?
Yes, please. We would love to see the poet. Thank you.
Hello, everyone. I hope you can see me now. I'm so grateful to be joining in this session. I'm overwhelmed, and please know my best gratitude to everyone. So, this is the poem that I wrote on hepatitis, but I did not know that it will be celebrated like this. So, it has become one of the most happiest days in my life. Thank you, Pauline ma'am, for giving me the opportunity to submit and giving me this opportunity to read this poem in this webinar. I wish everyone a good health and a safe and sound health, and of course, for a better world for everyone. Thank you. Ma'am.
So, Mr. Ehsan, please read your poem. We are all ears.
All right. Thank you. So, the name of the poem is Hepatitis, the Liver's Lament. Here we all lend ear and mind. Of hepatitis, truths we find. It creeps in silent without a sound, takes root in blood and spreads around. Fatigue and loss of appetite, weight that drops and skin turns white. Eyes grow yellow, fever flows, with itches in joints and belly ooze. These signs, if seen, don't delay. Go test your blood without dismay. For antigens and antibodies speak of hepatitis, the truth they leak. There is A and B, E, and hepatitis C too. Close to home, labs wait for you. A drop of blood can help detect what silent harm the virus wreaked. Acute or chronic, both may strike. Cirrhosis, cancer, looming like. A shadow cast from veins once shared. So guard your health, be well prepared. Spicy meals and greasy feast, alcohol binges, nightly beast, unclean syringes, reckless touch, all raise the risk, and that too much. Let good habits be your guide to keep this threat from growing wide. For hepatitis, though unseen, can steal away life's vibrant sheen. But hope is here. The vaccine's free for every child and grown up. See, though let you calm, you still may take to keep such truths in all our minds. And that shield of health is no mistake. World Hepatitis Day reminds to keep such truth in all our minds. With conscious steps and knowledge bright, we carve a path to health and light. Awareness is the strongest shield. Let life and joy be what we yield. Let happiness, let hepatitis fade from view, a world without it strong and true. Thank you, everyone.
Thank you so much, Mr. Ehsan. Thank you so much. This is indeed a wonderful tribute to the World Hepatitis Day and to the poetic discussion on what we feel.
Thank you so much.
I see a lot of positive hearts in this as reactions to this. Thank you so much, Mr. Ehsan Samad. And thank you for your dedication and being an advocate where you are as a poet. So without further ado, we have a survey for everyone. And Echo team, could you please put the survey there? And if you can click and to respond to the survey, it's really to have a little understanding of what we do know about the hepatitis. So go down to your voting part. And then if you can vote for the questions, they are a total of 5 questions. Hosts and panelists cannot vote. So we'll give you some time. Okay. Echo team, do we have an understanding of how many people have voted so far? I cannot see from my side.
Just now 91 participants have already joined this poll. They have submitted their answers. 92, I think the number is increasing.
Okay, great.
72% of the participants have already filled.
Right. And we will review the survey results during the discussion and the Q&A. So perhaps let's start the technical discussions now. Okay, so we'll start with the first overview presentation, which is on viral hepatitis in the Southeast Asia region. And that would be, and I will be presenting that on behalf of the WHO CRO. So Echo team, I'll be sharing the presentation now. Okay, can you see my slides?
Yes, Dr.
Thank you very much. We'll keep the poll and the survey open, and as and when you can also continue. So let's continue with an overview of the viral hepatitis elimination in the WHO Southeast Asia region. So what we have learned in the last several years of trying to implement hepatitis elimination by the SDGs 2030 is that it is absolutely critical to integrate services at the different service and health systems level using existing interventions, because it is not a new program. It's just using existing health programs at scale and under the umbrella of universal health coverage. What does it mean? If you look at the different services that is already in health, such as safe blood or safe transfusion, blood banking, vaccination and immunization programs, maternal and safe motherhood programs for prevention of mother-to-child transmission, universal precautions, safer sex through the HIV, STI programs, tests, drugs, and also harm reduction services for people who inject drugs and oral substitution as well. All these exist. It's just getting it to a coverage level that more and more people can access all the different services for hepatitis. So a little bit about the global reporting from the WHO Southeast Asia region. We have a substantial number of people living with hepatitis infection, a total of almost 70 million people infected with hepatitis B and C. Our overall prevalence is relatively low at a 0.3 or 4%. But what is important here is that there are not a lot of people who are diagnosed and treated. But interestingly, also enough, and very concerning, that 21% of all new HCV infections is actually due to unsafe medical infections in the region. And this is something that we can do better with better medical injections, sterile medical injections, and also better infection prevention and control. In hepatitis, our burden of chronic infections is substantial. We have challenges with low coverage of diagnosis. On the left-hand side, you can see the treatment cascade. We have a lot of people that require diagnosis, but not a lot of people who actually reached services and got treated. And in that sense, we have a projected increase in liver-related deaths and liver cancer due to hepatitis B and C to 2030 and beyond 2030. Regional hepatitis B vaccination coverage has improved over the many decades due to investments by country on universal childhood immunization programs, with a drop during the pandemic years. But there is a recovery, although it's not universal across all countries. But we have a birth cohort of babies that missed the hepatitis B birth dose. And as you can see from the orange line, the hepatitis B birth dose still remain suboptimal in the region. Over here, we want to highlight that many countries have had very good Penta-3 coverage, which is basically a completion of the 3 doses of pentavalent vaccines, even through the pandemic. So we would like to applaud Bangladesh, Bhutan, DPR Korea, Maldives, and Nepal, Sri Lanka, and Thailand, which has sustained the pentavalent coverage also through the pandemic. And in India, very critically, there has been substantial improvements in the coverage, and in 2024, an all-time highest coverage ever in the country. We still have the challenge of Myanmar and Timor-Leste, which is below target. In hepatitis B birth dose, we still have quite some challenges in several countries as well. Those that are highlighted by the yellow box are countries that require quite a lot of work in terms of trying to improve hepatitis B vaccination at birth. But moving beyond hepatitis B control through vaccination to really the initiative to ensure the well-being of mother and infant through the triple elimination of mother-to-child transmission. We have 3 countries that are champions and that have been validated for at least dual EMTCT of HIV and syphilis. And these are Thailand, Sri Lanka, and Maldives. And Bhutan is on track, but requires some work towards applying for validation of elimination. And CRO is working on subnational approaches with large and diverse countries, or at least we started the thinking around it. It's the next paradigm shift in triple elimination. And WHO will be supporting and is supporting countries on their pathways to elimination of mother-to-child transmission, including subnational approaches in several large and populous countries. Over here, I take India, that has substantially scaled up and progressed subnational initiatives through phasing up their implementation over the last 3 years. And this year, the government of India declared a mission mode implementation to improve screening and cascades of care for those who require treatment and continued care. We have also new emergent crisis in hepatitis among refugees in Cox's Bazar, Bangladesh, where there is 1.2 million refugees residing in this area. It is WHO's largest emergency among refugees. And our partner agency, MSF, found in 2023 very high HCV viremia, and there's been substantial scale up from WHO and all partners in trying to screen more and more refugees for hepatitis. And as you can see, there is hepatitis C infection also among pregnant women. Access to medicines are still challenging. We have the advantage in this region for different medicines and generic manufacturing of hepatitis in many countries. The benchmark for hepatitis B remains around $30 a year, which is still fairly affordable. For hepatitis C is around 60 to 90, but the reality is that it is much higher in many countries. So there is still some work to be done for access to hepatitis. Some of the key takeaways for hepatitis elimination in the region is that when we want to talk about eliminating hepatitis, it is based on a set of actions in preventing new infections and in treating those who are infected. Liver cancer is preventable. It is mostly due to hepatitis B and C in Asia and in this region, and earlier detection by testing is better before cirrhosis or liver dysfunction happens. What can we do concretely together is to strengthen service delivery and coverage of existing health programs, whether it is blood safety or it's condom use in key populations or it's harm reduction and oral substitution of drugs or for people who inject drugs. So, and for us, really importantly, is to turn off the tap of new infections through vertical transmission, through triple elimination of mother-to-child transmission. And we encourage countries to test, to treat more, and get to ensuring that no one risk the development of liver cancer through this preventable disease. Cancer is preventable. And it's about the actions today to impact tomorrow. We can prevent liver cancer today. But what we need to do is to have active case finding, which means the test, to link together those who are infected and treat them. Because at the end, these are modifiable diseases that can impact liver cancer. So what we have seen across all countries when we do modeling studies and the data surely is that we can reduce the liver cancer by a lot in the next 20 years or 30 years beyond 2030, and to reduce liver cirrhosis as well. But we have to test and we have to treat. Thank you very much. So shall we have the next speaker then? Please do put in your questions and answers, questions so that we can answer them in the Q&A as well. And I would like to now invite Miss Rachel Halford and our very good partner agency from the World Hepatitis Alliance. And she will talk about beating cancer through hepatitis elimination, working together to drive action. Over to you, Rachel.
Thank you, Pauline. And I'm just going to share my slides. Let's go. Okay. Can you see my slides okay? Oops, let's go for the... There we go. I hope everyone can see my slides. Pauline, can you just confirm that?
Yes, I confirm. Thank you.
Fantastic. Thank you so much. And thank you. Good morning, everybody. Or sorry, it's good afternoon. It's morning for me, but good afternoon. It is such a pleasure to be here with you in this webinar, this really important webinar. And I'm going to present today on a particularly close to my heart topic, reframing hepatitis elimination as not just a liver health issue, but a broader cancer prevention strategy. So today I'm going to talk through the World Hepatitis Alliance white paper, Beating Cancer Through Hepatitis Elimination. And first of all, just to put this into context, within the white paper, the Alliance is advocating for hepatitis elimination to be recognised as cancer prevention within national NCD strategies. As highlighted by our previous speakers, many liver cancers are preventable through hepatitis testing, treatment and vaccination. Yet progress in integrating funding hepatitis measures into cancer control plans has been slow, with hepatitis-related liver cancer deaths projected to double from that 1.3 million to double by 2040. yet public awareness remains low. The Alliance research shows that 42% of people globally don't know viral hepatitis is the leading cause of liver cancer. So to tackle this, the Alliance launched a white paper titled Beating Cancer Through Hepatitis Elimination, working together to reduce NCDs. And we did this at the World Health Assembly in Geneva. It was developed with hepatitis and cancer experts, and it presents policy recommendations across 5 key areas: awareness, vaccination, testing, treatment, and monitoring. And I'm going to talk a little bit about those in my slides. This paper serves as an advocacy tool for both health professionals and communities to urge governments to integrate hepatitis and cancer services. So I'm going to very briefly talk through some of the 5 recommendations, just with a little bit of the human impact in the middle of it. So just first of all, from Ibrahima, the impact on him with liver cancer. He was physically, morally, and financially devastated, exhausted by repeated checkups and examinations and treatment with side effects. He was suffocating from taking out 2 loans, in addition to having to sell his house and his car to cover medical expenses. He was the victim of stigmatization in the workplace. And I think it's really important that we are aware of all the human impacts within this. So, our first call to action here is to integrate hepatitis testing, as we've already heard from Pauline just now, treatment and vaccination into funded national cancer programs to decrease the incidence of liver cancer and increase early diagnosis and therefore reducing mortality. Awareness. So research conducted, as I've already said, by the Alliance showed that 42% of people were not aware that hepatitis is the leading cause of cancer. And we have a quote here from RPS, and I think many of you will know him. Everybody knows what cancer is and that it's a killer disease. We need to make people aware that liver cancer can be prevented by preventing hepatitis. So our call to action around awareness is to implement national awareness campaigns linking hepatitis and liver cancer to increase uptake of preventative services, including hepatitis testing, treatment, and vaccination. Vaccination, as we've already heard, is really important. So the hepatitis B vaccine, I'm sure many of you already know, was the world's first cancer preventative vaccine when it became available in 1982. And it's been adopted in many strategies and policies, but there are gaps that persist. The hepatitis B birth dose is critical, yet only 58% of newborns in the WHO Sierra region received a dose of the Hep B vaccine within 24 hours in 2022. And again, the human impact. And this is Leanne, who used to sit on the WHO board. I told my mum I had hepatitis B and she blamed herself really badly, because when I was little, she tried to get me vaccinated for hepatitis B, but couldn't. I'm so glad today that children are able to receive the vaccination right after they are born. I hope that no mother will suffer from the same feelings that my mum did. So our call to action on vaccination is to expand timely access to universal hepatitis B vaccination at birth to prevent mother-to-child transmission. And then the other is to integrate costed Hep B vaccination for children and adults into all national immunisation schedules and cancer control plans and strategies with indicators as part of monitoring and evaluation. So testing, our next area. Early diagnosis of hepatitis can ensure people are linked to treatment and care, which reduces their risk of developing liver cancer. We know this. But only 2.8% of people living with hepatitis B and 26% with C have been diagnosed in the WHO Sierra region. There is a lack of robust national testing globally, national testing programs globally, and limited capacity in many countries is driven by a lack of accessible, as we've just heard, and affordable tests and limited training for healthcare professionals. So our call to action for testing: integrate testing for viral hepatitis into national cancer and NCD prevention and control strategies and delivery programs with indicators which are included in the monitoring. Increase training for healthcare professionals, on hepatitis and its connections to liver cancer, to expand access to testing in clinical settings, and enable community primary healthcare services, community-based organisations and trained peers, and I'll talk about that in a minute, to offer community-based testing for hepatitis, in addition to testing provided for, very importantly, healthcare workers as well. A quick snapshot of treatment. Hepatitis treatment is cancer prevention, and this is really important, and this is key to the message. Only 1% of people, though, living with hepatitis B and 14% with C received treatment globally in 2022, or received treatment globally in 2022 in the WHO Sierra region. So antiviral treatment on our actions, our call to action is to include hepatitis treatment within national cancer and NCD action plans, strategies and program. It prevents or slows progression of chronic hepatitis to liver cancer. And really importantly, ensure equitable, affordable and sustainable access to quality assured hepatitis treatment, including through public health mechanisms, by expanding eligibility and offering treatment in accessible settings. This is really important, where treatment can be accessed. Finally, monitoring and early detection. Monitoring is really important. Monitoring people living with viral hepatitis for liver cancer can lead to early detection, treatment, and far better outcomes. People diagnosed with liver cancer at an early age have a survival rate of greater than 70% over 5 years, compared to those with advanced liver cancer, which has a 20% survival rate over the same period. So monitoring, and a little quote here from RPS again, who, I'm sure many of you will know his story. In spite of taking my hepatitis B treatment and participating in HCC screening programs, I developed cirrhosis and malignancy, but it was caught early. My knowledge and regular attention to screening helped ensure that my tumour was caught as early as possible. It's so important. So our call to action: to implement and expand HCC, so liver cancer surveillance programs that include all people living with or cured of hepatitis. This is to increase early diagnosis and treatment of liver cancer. Invest in research and development of accurate and more sensitive surveillance and diagnostic methods for liver cancer surveillance to improve patient outcomes. Strengthen and link cancer and hepatitis data registries to improve monitoring and evaluation and inform the healthcare system's responses to liver cancer. Empower civil society organisations, and of course I'm going to say that, and peers, to support HCC monitoring. They have a crucial role to play to improve the uptake of liver cancer screening and improve understanding of barriers to accessing liver surveillance programs to increase uptake. So just a quick example here. So, I run the Hep C Trust in my day job. I'm currently president of the World Hepatitis Alliance, but in my day job, I run the Hepatitis C Trust. And we run liver surveillance programs where people go out in vans and deliver liver surveillance, particularly to those which are the hardest to engage. It is a crucial role that civil society can play. And just before I end, I wanted to quickly touch on the cost effectiveness. Countries should invest in hepatitis services as part of universal health coverage. Every dollar invested to prevent liver cancer deaths returns more than double the value to the health system. So it's actually a no-brainer. Hepatitis B vaccination is highly cost-effective in preventing liver cancer cases and reducing hepatitis B-related mortality. New modelling at the Centre of Disease Analysis Foundation in several countries with different income levels but similar preferences of hepatitis B and C found that reaching the WHO hepatitis elimination targets for testing and treatment by 2030 was either highly cost-effective or cost-saving in all countries by 2045. So, conclusion. Policymakers must act now to integrate costed hepatitis services into fully funded national cancer control policies and programs to reduce the burden of NCDs. By integrating hepatitis and NCD programs, policymakers can make health systems stronger and more cost effective. And with concerted efforts together, we can prevent liver cancer by eliminating hepatitis C. So if you would like to read more about the, oh, my slide won't work, to read more around the white paper, please, you can scan this. But thank you so much for asking me to speak today. It's an absolute pleasure. And I look forward to any questions. Thank you, Pauline.
Thank you, Rachel. Our next speaker is Dr. Manya Prasad, who is formerly from the WHO Collaborating Center and has now moved to AIIMS Delhi in India. So when we were talking about the work that the synergies and the common agendas that we have between hepatitis elimination and NCD cancer and our colleagues in cancer, working in cancer, we thought, we needed to understand what was the landscape of liver cancer and the major risk factors in the Southeast Asia region. And then we asked Dr. Manya and the team to help us to get this done. So Dr. Manya is now going to present the results of the scoping review on the regional landscape of liver cancer and major risk factors. So we are all ears, Dr. Manya, so over to you.
Thank you. Thank you so much, Dr. Chan. I'm grateful for the opportunity to present at this webinar to commemorate the World Hepatitis Day. So I will share my screen now. Could you please confirm that you can see my slides?
Yes.
Okay.
Please proceed.
So I will present results from a scoping review for the burden of liver cancer in the Southeast Asia region. So what this will contain is very briefly the methods considerations for this scoping review. I'll tell you a little bit about the sources that we delved into because that has very important implications for interpreting the findings. Finally, give an overview and the profile of burden across the different countries in Southeast Asia region, and a little bit about etiology-specific and region-wise burden, and also a little bit on projections to the future. So this was a protocol-driven review, and we set out with the objective to document incidence rate, prevalence, mortality, DALYs, so a measure of morbidity burden, which is disability-adjusted life years, for liver cirrhosis and HCC. And we wanted to document the geospatial distribution with special emphasis on pockets of high burden, and then finally delineate the knowledge gaps that we need to address to inform future research and policy. And the methods adhered to the PRISMA checklist for scoping reviews and the synthesis without a meta-analysis guidance published in the BMJ. We looked at published literature in electronic databases, and we searched 4 main databases. But we also wanted to include data from gray sources of literature. So gray literature including government reports and relevant Ministry of Health websites. And of course, the 2 main sources of estimates, which is IHME and the WHO Observatory. So across these 4 databases, we got 3,374 hits, which we screened on this online software called Ryan. And after screening titles and abstracts and full text sequentially, we were left with 23 studies, which we have included in this scoping review. Now, right at the outset, it's important to note that when we talk about regional estimates for burden of liver cancer, we have 2 main sources. The first is the Global Cancer Observatory, which is aligned with the IARC, International Agency for Research in Cancer. And the second is the Global Burden of Disease Study. It's important to note, of course, that they have vital differences with regard to data sources and the included countries, including also methods for the modeling estimates that they provide. So important methodological differences are there between these two estimates. But what is most challenging when we talk about reading or obtaining these estimates is that they are not aligned with regard to country groupings. So the way that they cluster countries into regions is not exactly aligned. So which is why it is difficult to make a comparison directly from these two estimates. However, we have disaggregated the data from GBD and tried to make relevant comparisons wherever possible. Of course, when we talk about disaggregating the data from the regions, it's important to note that the Seuro region comprises of countries where data sources are sparse. So this is a map of the number of sources that we have for each country within the GBD database. And you can see here the lightly colored areas or the lightly colored countries in this map are the countries that have very limited data sources, and a number of Seuro regions are included. So the Seuro region is included here in this sparsely data sourced country. So the implication for this is that a number of assumptions have to be made, and the GBD estimate should be interpreted in that context, that the model estimates are only as good as the assumptions that inform the model. However, when we make a comparison of these two sources, they are largely aligned in terms of the estimates that they provide. So you can see here that in this line graph, there's high correlation between the estimates from the GBD and the GCO. However, we also observed that quite often they are not in alignment. So we noticed opposite trends in 8 standardized rates for 10 countries. And for the projections that were provided, we noticed that there are opposite trends for 7 countries. And this was mostly due to incomplete cause of death registration, which is there for a number of LMICs. And this corresponded as expected to the Human Development Index of these countries. So globally, of course, we know that liver cancer is up there in terms of incidence and mortality. It ranks 6th globally in terms of incidence, and in mortality, it's the 3rd highest burden for deaths. But starkly, you can see here that this pie chart depicts the distribution of the burden of this disease of liver cancer across various continents. And you can see here that Asia comprises actually a very large proportion of this burden. Now, coming on to the region itself, this is a table that maps the incidence and the deaths from liver cancer. And the key messages from this table are 2. The first is that although there are certain countries in the region that have low numbers in terms of incidence, so you can see here Bhutan has low numbers and Maldives has low numbers. However, when we talk about mortality, liver cancer still figures very high up there in terms of ranking when we talk about cancer deaths. So you can see here that when we talk about the top 4 causes of cancer deaths, liver cancer figures 4th within those 4, within the 4th rank for Bhutan, for Maldives, for Myanmar, for Nepal, and for Timor-Leste. And the second main message here is that burden is high and it is relatively uneven across the region. The country, of course, with the highest burden in Seuro is Thailand, which figures at the top in terms of both incidence and deaths, and also has an alarmingly high rate of cholangiocarcinoma. What is also prominent across the region is that much of this mortality and morbidity is still driven by viral hepatitis. So for Bangladesh, India, DPR, Korea, Myanmar, and Timor-Leste, the key cause for liver cancer, morbidity, and mortality remains hepatitis B and C. So these are the numbers overall, around 107,000 new liver cancer cases and 103,000 deaths. And as I mentioned, Thailand is the highest burden. A number of countries within the region still demonstrate very high mortality for HBV and HCV. And although some countries show small numbers, but they still have very high burden for mortality. Another very important consideration for this region is that around 17% of liver cancer cases in Southeast Asia are in the 15 to 49 age group, which means that it's affecting younger age groups. And this is a map from the GBD that maps out the 8 standardized rates across the region. And you can see here that it's highly variable, which can range from less than 3 to over 14. However, it does remain high in terms of burden. If we talk about etiology-specific age groups, 8 standardized death rates, we can see here that for hepatitis B cirrhosis and hepatitis C cirrhosis, the Southeast Asia region outruns both the global as well as the Western Pacific burden in terms of deaths. And therefore, at least for Southeast Asia region, HPV and HCV remain as very important causes of liver cancer deaths. And this is also reflected in this table, which depicts the annual percentage change of 8 standardized deaths. And the main message from here is that when you look at the time trend from 2015 to 2021, the greatest increase in 8 standardized death rates related to liver cancer occurred in this region, which was an annual percentage change of 0.71%. This table depicts the etiology-wise trend, and you can see here that, of course, fatty liver and alcohol are increasing in terms of having a greater stake in the etiology. And hepatitis B and C trend-wise has a reducer, has a less stake if you talk about temporality. Overall, we can see that, of course, the deaths are increasing. You can see that in this table, which depicts the percentage change of 8 standardized death rates, which is increasing for Southeast Asia region. And for mortality, which is depicted by the DALIs, also there is an increase with an 8 standardized rate of 177.5 if we compare 1990 to 2021. And these are the studies that have contributed to these estimates. In terms of projections, lastly, we see that if we talk about the estimated number of new cases, China is still projected to have the highest burden of cases till 2040, followed by India and then a number of other countries within the region. And therefore, it is estimated that although the 8 standardized rates will remain constant, but due to aging population, the number of cases and the number of deaths are expected to increase till 2040. Lastly, we mostly talk about primary liver cancer, but it's important to know that cholangiocarcinoma is also an important cause apart from HCC. So we have seen that HCC increased in a number of regions. However, with regard to Southeast Asia region, intrahepatic CCA remains a very important concern. Lastly, if we talk about the challenges in estimating burden, it has come out very clearly from this review that there are very important barriers in estimating the burden for Southeast Asia region, particularly due to, as I mentioned, different country groupings in the sources of the estimates. The lack of population-based cancer registries. So a number of countries have only hospital-based registries, or a number of countries don't have registries that can provide estimates. Also, liver cancer itself is underreported. And because of limited data sources, the estimates from GBD rely mostly on assumptions, and the model is only as good as those assumptions. And finally, we searched a number of ministry websites and gray sources, but disaggregated data is not available, and therefore grade literature access remains a challenge. Of course, the steps needed that came out were that we need preventive measures, including vaccination programs, screening protocols, and treatment approaches based on etiology, including tailoring treatment strategies for a more patient-centered approach. Thank you very much, and I'm happy to take any questions.
Thank you, Dr. Manya. And as we are kind of getting tight on time, Dr. Bishnugiri, over to you for your presentation, and then that will be followed by discussions and Q&A. Over to you, Dr. Bishnu.
Thank you very much, Dr. Pauline. Is my screen shared? Can you confirm, Pauline?
Yes, I confirm. Please proceed.
Thank you very much. Good afternoon, colleagues. First, I'd like to express my sincere thanks to Dr. Pauline and the whole team for organizing this webinar and letting us forum to emphasize the growing burden of liver cancer in the Southeast Asia region. I will not be taking very long time because my presentation is more or less a summary of what the presentations have been so far. We have already come across this figure. So globally, liver cancer is the 6th most common cancer and 3rd most common cause of cancer deaths. And even in terms of age-adjusted incidence, it ranks quite high and in terms of age-adjusted mortality as well. In the Southeast Asia region, it is the 7th most common cancer in terms of number, almost 107,000 cases estimated in 2022. This is as per the GloboCan data, which Dr. Manya also presented. And there has been the number of deaths is very high. It's almost 97%. And liver cancer is within the top 5 most common cancers in 6 countries in the region. And if we look just among the males in the entire region, liver cancer is the 2nd most common cause of cancer deaths. So it's definitely a very important cause of cancer mortality and increasing in the increasing burden. This data Dr. Manya also presented. It's from GloboCan again. In Thailand, liver cancer is the leading cause of cancer deaths. It's the number 1 cause of cancer deaths. It is also the highest cancer incidence as well. We're talking about mortality now. And in liver cancer is the 2nd most common cause of deaths in 3 countries. That's you can say DPR, Korea, Maldives, and Myanmar. And in Timor-Leste, it is the 3rd leading cause of cancer deaths. And in Bhutan, it's a 4th leading cause of cancer deaths. If we look just into at the male population, even in Nepal and India, liver cancer is 3rd and 5th leading cause of cancer deaths in the country. So it's a huge burden. So how can we prevent liver cancer? This has been discussed in detail already in all the presentations before this. And I guess there is a question also in the Q&A box about the risk factors. So the most important risk factor for liver cancer is chronic hepatitis B and C. So both of these lead to are the etiological agents for hepatocellular carcinoma as well as intrahepatic biliary duct carcinoma, basically liver cancer, the term that we generally use, and even in some of the estimates that we have presented, both the cancers are included. So 75% of the cancers are because of hepatitis, and that's the most important message that we all the presenters want to deliver in today's webinar, that hepatitis B and hepatitis C are the most important cause for liver cancer, and they are preventable. So the next important risk factor is alcohol. So if I think there was a question in Q&A, what is the role of alcohol, banning alcohol for prevention of liver cancer? So up to 17% of liver cancer could be avoided if alcohol consumption is avoided. But how effective those programs will be, that's another question. And there are some other contributing risk factors, risk factors also, including liver cirrhosis, aflatoxin from contaminated foods, and tobacco smoking also contributes to liver cancer. So risk factors important because all of this are preventable. So liver cancer is a preventable cancer, very much preventable cancer. That's one important message that we want to convey today. In treatment, we will not be going into the details of how liver cancer is treated, but generally it involves surgical resection and ablative therapy. It also involves liver transplantation after surgical excision, chemoembolization, delivering the chemotherapy in this site specific for liver cancer. That's another interventional methodology for treatment, and there are systemic therapy, systemic chemotherapy, as well as immunotherapy, and there are quite a number of emerging therapies which are promising. However, I would like to emphasize what we see in this graph. When we talk about treatment, we have to know the outcome. This graph is for the Southeast Asia region, all the Southeast Asia region countries combined. The line on the top part is for incidence, and the one in below that is for the mortality. The continuous line shows the number. Excuse me. The line on the top is for the males, and the one below is for the females. Apologies for that confusion. The continuous line indicates the incidence, the number of cases, and the dotted line shows the deaths. So what we can say is that they are almost overlapping with each other. So the number of new cases and the number of deaths are almost equal. And this is a projection from 2022 till to 2050. The numbers are expected to almost double, and almost all of them are estimated to be dying of the disease. Currently, the mortality to incidence ratio for our region is 97%. So if 100 cases of liver cancer are diagnosed, 97 of them are dying. So it's almost a kind of a death sentence. That's our the fact that where we stand now. And given the technological limitations, the aggressive nature of the disease, the survival rate is not very encouraging, even in high income countries with all the resources. The mortality rate in high income countries is almost 80%. So the main message, another main message that we want to convey today is that liver cancer is a very, very aggressive disease, and prevention is the key to controlling the disease. So prevention is important. Treatment is not very effective, as we see from the data. So just to list out some of the things that we are doing at the regional level, at the level of the countries, we have developed a regional strategy for cancer prevention and management last year. Just to, as Rachel has pointed out, the cancer strategy and plans should include hepatitis control as an integral part of the strategy. And our regional strategy does integrate this and acknowledges the existing regional strategies on vaccination, as well as on the control of HIV, hepatitis, and STIs. So we have an integrated approach, and the countries are in the process of adopting this regional strategy into their plans. In terms of vaccination, as Pauline has already said, we are doing quite well in terms of per dose vaccination, and there is a scope for still further improvement in the birth dose vaccination. One of our focus or approach in strengthening the management of cancer in the region is through the Southeast Asia Cancer Grid. So this is a network of leading cancer service provider institutions in the region, across the countries in the region, established with the aim of fostering collaboration, where the institutions with relatively stronger capacity in one area will support another institution in the same country or in another country to build their capacity in that particular area. So we have seen the establishment of a lot of bilateral collaborative works ongoing, and some works which are taken up by the grid as a whole. And although the results are not yet out, the fruits of the work, but it's progressing, and maybe we will hear the outcomes very soon. SEEK grid mainly focuses on the areas of early detection, early diagnosis, and treatment, as well as palliative care, and focusing on capacity building, including human resource, and improving the quality of care. So as said earlier, there are some key messages that we want to convey today. One is that liver cancer is emerging as a leading cause of cancer burden in the Southeast Asia region. Treatment is not very effective. Prevention is effective. And prevention is achieved through hepatitis B vaccination, through treatment of hepatitis B and C, and avoiding the consumption of alcohol and tobacco. Of course, there are many more, but these are the important ones that we should be highlighting on. I would like to I would like to bring this graph presented by Pauline again, that we have been doing good in terms of vaccination, and there are some efforts or initiatives ongoing in improving the management, diagnosis and management also. However, we see that there is a very significant gap in terms of delivering treatment for infective hepatitis. So this is some area in which we need to focus on. And this is treating hepatitis B and hepatitis C is one of the effective ways of preventing liver cancer. And that's the most important message that we want to convey today. Thank you very much. That's all from me. Over to you, Pauline. And happy to take any questions.
Thank you very much, Vishnu. We have had a lot of questions and answers, so questions as well. So I'm going to pass on the mic over to Karina, who will take over the discussion and Q&A. But again, I would like to stress the discussions that we had today, that liver cancer is preventable. 75%, that means 2/3 of liver cancer is due to hepatitis B and C. And if you test people, you find them to have hepatitis B and C, you treat them, then liver cancer risk will go down. And that is the message really for today. We must do prevention of hepatitis through mother-to-child prevention of mother-to-child transmission, triple elimination. We have to ensure infection prevention, control, and safe blood services, safe blood transfusion. But really importantly for liver cancer is we have to test more people, make sure that they know their status, and if they are infected, provide treatment. Because that's the only way we can prevent liver cancer. Over to you, Karina, for the moderation or for the Q&A and the results of the survey.
Thank you, Pauline. Thank you overall to all our presenters, Pauline, Dr. Manya, Dr. Vishnu, and Rachel, for the insightful presentations today. Can I call on the technical group to perhaps present the findings or the results of the poll that we had earlier? Thank you. So we had 5 questions. What damages the liver? Is actually all of the above. So viruses, alcohol, and fat can all damage the liver. Hepatitis can lead to liver cancer. The answer is true. And we have 97% getting that right. Question number 3, is there a vaccine that can prevent hepatitis B? And the answer is true. Yes, there is, 97% correct. Is it true or false whether hepatitis C is curable? And this is the message that we want to project today. The answer is true. So we only have 86% correct today. So I hope by the end of these presentations, we all get the message that it is curable for hepatitis C. Liver cancer can be prevented by prevention of hepatitis. And yes, that is true. So we can have 95% getting that correct. So Those represent basically the key messages for today's four presentations, and thank you again, all presenters. We have quite a busy Q&A session, so I do encourage you all to read through. Mainly, most are already answered in the chat, but the main questions are to do with, let me quickly go through. Perhaps I will actually invite Pauline to address the question on birth dose of hepatitis B. She has answered this in the chat, but there is question on the difference between a 24-hour after birth compared to the 2 weeks after birth, and also whether WHO is coming out with the recommendations for hepatitis B birth dose vaccination. Over to you, Pauline.
Thank you very much. In terms of hepatitis B vaccination, hepatitis B is among the first cancer prevention vaccines. And really important is that what we are trying to do is to prevent transmission through vaccination, and it's a highly effective vaccine. So the best period for baby and the recommendations from WHO is to get the birth dose within 24 hours of birth. And now WHO also has guidelines, of course, not just the birth dose for hepatitis B vaccination, but the completion of the immunization schedule, including the more and more countries, the 3 pentavalent vaccines, which contain the hepatitis B component. So in total, the babies in Southeast Asia region will get the 4 dose. So birth dose plus the 3 pentavalent vaccine to prevent and provide lifelong protection for the baby for hepatitis B. Now, in terms of prevention of mother-to-child transmission, it is also important because many countries have established universal screening for hepatitis B so that further interventions using hepatitis B immunoglobulin and or the use of tenofovir, the antiviral drug, to further reduce the viral load in the mother and thus prevent mother-to-child transmission. So these in addition to the immunization to the baby. So these are all additional prevention strategies that combines immunization, additional prophylaxis using immunoglobulin, and use of antiviral drugs to prevent vertical transmission, to really reduce the numbers of babies that may or are at risk of infection. So this is quite critical, and WHO has all these information in the website. Thank you.
Thank you, Pauline. There's also quite a few new questions, and pretty much overarching question is regarding treatment of hepatitis. For hepatitis B, is it a treat-all strategy? And why not? If not, why is it not treat-all strategy for hepatitis B? Perhaps maybe Dr. Giri or Pauline can take this. May I invite one of the panelists to address treatment of hepatitis B?
Okay, thank you very much. So in hepatitis B, there are different practices across the globe and in different regions, and also in different countries. The WHO latest treatment guideline for hepatitis B, released by WHO in 2024, actually provides a very wide scope of potential for clinicians to treat patients. So up to an estimated almost 50 to 60% of people could be treated through the WHO current guidelines now. So please look at the WHO latest guidelines on hepatitis B that can guide clinicians on treating of hepatitis B. But like anything, when you start treatment for hepatitis B, the considerations for any chronic infection is about lifelong treatment and lifelong adherence. And we have learned from the HIV program and treatment experience that adherence to a daily dose of drug can be quite challenging. Also depends on the person and the lifestyle as well. So this is quite important when we discuss with policymakers, national programs, and individuals and patients about treating everybody or taking a lifelong treatment. Thank you.
I will read out also a message from Dr. Sigrun Russell, our IVD advisor. In terms, her comment is that in terms of timely hepatitis birth dose, that the HBV can infect liver cells within hours of exposure at birth. The vaccine works by priming the immune system before infection is established. So once the HBV virus reaches the liver, chronic infection risk is high, up to 90%. So that's another reasoning to add to the dose timing. Thank you, Siggy. Okay, in the interest of time, I'll just highlight one final question. There are details asked with regards to data on India versus Thailand, but I believe Dr. Maya has addressed that also in terms of why the incidence and number of cases in India and Thailand are different, but Thailand is ranked as #1, and it's to do with absolute numbers. And there is also a question on whether hepatitis B can be cured. So there is no cure for hepatitis infection for now, although there is work ongoing. Okay, I think we can move on. And I do encourage everyone to quickly have a look at their answers in the chat box. Let me quickly see if there's anything in the global question that we can address. I think that's it. I will actually, before we end, would like to go around with all the panelists, perhaps to give one key message or one takeaway call to action or your main summary with regards to viewing viral hepatitis infection as a risk factor for cancer and the opportunities for control and strategies. So perhaps I will start with Rachel, over to you. And you have beautifully highlighted the 4 main call to action. Perhaps if you could summarize it as one let's go message. Over to you, Rachel.
Thank you very much. Yeah, I think what I'd like to say is that we don't talk about this often, but when somebody has liver cancer, it's a very long and distressing death. It's horrendous. You know, what happens to somebody when their liver deteriorates. No one needs to die from liver cancer. There is a vaccination. If we raise awareness, there is treatment. So there's a vaccination for hepatitis B, there's a treatment for hepatitis C. We have systems that we can integrate within to ensure that awareness is raised and that we can monitor and do HCC screening. It's so important. And it's, you know, I lost my best friend from liver cancer. She didn't need to die. There's treatment for hepatitis C and there's a vaccine for hepatitis B. We need to integrate and we need to raise awareness and stop this figure from doubling in the next 10 years. And I think I'll leave it there.
Thank you, Rachel, and thank you for putting the reality and the human factor in all of this discussion. It's very important for all of us. And over to Dr. Maya, especially with the findings of the work that you did, what would be your main takeaway message? Over to you, please.
Thank you. So not to repeat what Ms. Rachel said, but to give a different perspective for policy implications, I think it's important to also at the policy level encourage good data. So we need population-based registries. We need robust ascertainment of the etiology-specific burden. And we need good data sources that can give us an accurate estimate of the burden within the region. And that has very important policy implications. And in terms of public health measures, I think if I had to stress one, it would probably be the birth dose, which is probably suffering the most in terms of implementation. Thank you.
Thank you so much, Dr. Maya. And Dr. Giri, over to you for some final words. Thank you.
Thank you very much. The key message that would be important for today is that although there are efforts on improving the treatment outcome for liver cancer and there are medical breakthroughs happening, the access to those treatment is limited, and currently available treatment do not have a very encouraging outcome. So the best way to control liver cancer is through prevention, and prevention through vaccination and treatment of hepatitis B and C. And one area of attention that we may need is, while we raise awareness about this fact that liver cancer can be prevented by preventing hepatitis B and treatment hepatitis B and C, let's also make sure that we take enough precaution to not increase the stigma of the disease that is already existing there, which is already very bad. So let's convey the message in a more positive way. I'm saying this because most of the participants today, our colleagues are health personnel. So just to take care of that. Thank you.
Thank you. And with that, I will close the discussion and Q&A session. And to close the whole webinar, I'll hand over to Pauline. Thank you, Pauline.
So I thank basically all the participants. We had very active discussions across the whole arena from hepatitis and liver cancer. And I would like to first thank our distinguished speakers, Rachel, Dr. Manya, Dr. Giri, and also for the support of our CDS, our director from WHO, CRO. I would like to thank Karina for moderating and working along the backstopping the preparations of this, and our team in the regional office, Balraj and Smriti, and especially to the ECHO team as well. So there is a reminder from the ECHO team on the feedback for today's session and what you feel will be useful going forwards, because it will help us to design forward the different webinars. Especially really today, in commemoration, we also heard from our distinguished Bangladeshi poet who recited his poem. And it's a reminder of, it is not the numbers, it is not what we do today, it's what we do every day to talk about hepatitis, to advocate and to reach out. So together we can talk about it, and we can do the actions, and we can make the actions to get to hepatitis elimination by 2030, which is in a few years' time. Thank you all for being here today, and have a nice day ahead. Bye.
Thank you.
Thank you. Bye.